Okay, here we go. I wanted to take a moment to welcome everyone. I'm Dr. Monica Dweck. I'm the Director of Career Planning Services for Mount Sinai Medical School. And tonight we have Lori Katinas joining us for our Alumni Connect sessions, where we have an alumnus from the institution talk to you about their journey and their choices and their challenges and anything else that might be important in terms of how they chose where they are now. And then we'll open up the floor for answering questions. Dr. Katinas, why don't you introduce yourself?
Sure. Hi, everybody. My name is Lori Katinas. I was Lori Refrano back in my Sinai years. So let's start a little bit about my journey, and then I'm happy to answer any questions and go into things further. I grew up in New York, and I went down to college at Duke University for 4 years, decided to come back to New York and came to Mount Sinai for medical school. Graduated from medical school in 2002. At that point, I was absolutely set that I was going to do, going into medical school, I was absolutely set that I was going to be doing pediatrics. I had done pediatric research when I was in college. And then when I did my rotation in medicine as a third year, I thought it was incredible for many reasons. I thought it was complex. I liked the diversity of cases that I saw. I thought it was fascinating following people through multiple years of life. And it was very interesting to me. So I actually changed from pediatrics to internal medicine in my third year. I stayed at Mount Sinai for residency. So I did my 3 years of internal medicine residency at Sinai. I did a chief year at Sinai. Then I went on to do geriatrics and palliative care fellowship, which was 2 years. And from there, I took a job out on Long Island. So for 10 years, I was with LAJ, now Northwell. I was at LAJ and North Shore, which is part of Northwell Health. And I've done a combination of geriatrics, palliative care, and internal medicine, both a little bit inpatient, a little bit outpatient. And right now, just because of family changes, I'm actually doing nights as a hospitalist. So that's kind of the short version of my journey.
Can you share with us perhaps what some of the challenging questions were asked of you during your residency interview?
So my residency interviews, I have to say, I remember them being really interesting. And so I remember going to, quite a number of hospitals at that time. And I always thought that the most challenging one for me was, where do you see yourself, in 5 years and in 10 years? Because at that point, I knew that I loved internal medicine. I still thought every field in internal medicine was amazing. And I went through wanting to go into ID and wanted to go into cardiology and wanted to go into critical care. And every time I did a rotation in any of those fields, that's what I wanted to do. So I felt like trying to pinpoint myself to an actual career choice 5 to 10 years from now was very hard. And so when I answered the question, I was very open about it and essentially said, I enjoy research, I enjoy clinical medicine, and I enjoy teaching. And I'm hoping that part of my residency will be will help me to sort of decide what I enjoy the most now that I'm kind of immersed into my field.
Dr. Dweck, I think you might be on mute.
Thank you. What would you consider to be the biggest lessons you learned during your residency at Mount Sinai?
So even now, I've been attending for, 12 years. My residency was probably one of the best times of my life in medicine. I just love the camaraderie, the hard work, the incredible cases. I thought one of the most amazing things at Sinai for me was the diversity of hospitals that we were able to go to. And, for example, we were at Elmhurst Hospital where we would see one kind of group of patients, and then we would be at Sinai, and then we would be at the VA. I thought it was one of the most exciting times in my life practicing medicine. And I love the group of people who I had worked with.
How would you say the pandemic has affected your work?
So the pandemic has affected my particular work very hard. So as a hospitalist, we are the frontline doctors taking care of the COVID patients. So right now I'm working at NYU Winthrop Hospital in Mineola. And my job as a hospitalist at night is we admit patients from the ER, we cross-cover the patients on the floor. We do a lot of teaching. So we have PAs, we have NPs, and we have residents overnight. And for the COVID cases, we are the primary service. So anybody who comes in with COVID comes to our hospitalist service, unless they go to the intensive care unit. The intensive care units having filled up very quickly, we took, and I think it's probably the same at Sinai, we took a lot of critical care patients onto the floor. So we were managing vents. I mean, it's been years since I've managed a vent. We were managing vents, and we had hypotensive patients, and we had patients having STEMIs. You know, we kind of had the gamut of patients on our regular medical floors, and it was challenging, and it was a lot of patients, and it was a lot of, again, probably like Sinai, group effort to try to absorb these patients and care for them.
Great. So do you foresee any changes in the landscape of internal medicine down the line?
So I think, you know, there's sort of the inpatient world and the outpatient world, which are both incredibly different. So I think in the outpatient world, certainly telemedicine is becoming a huge thing. And so a lot of my colleagues who are in internal medicine as an outpatient are doing a lot more telemedicine. It's something we never trained for, you know, and I was a resident, and certainly in my years as an attending up until now, telemedicine wasn't something that even existed for us. So that is a huge new frontier for outpatient medicine. For inpatient medicine, I would say now on the medicine floors, whereas sort of real sick, complicated patients would often go to the intensive care unit, we are taking care of much more sick and intensive care-like patients on the floor, trying to sort of make do with what we had. There's the triaging that we have to do from the ER is a lot more intensive now with COVID, and you know, how do you ration the beds out? You know, that's something that we all are part of doing as well. And there's a whole new level of teaching, you know, teaching the residents and teaching the PAs how we're going to take care of these patients, how we prioritize things.
Great. So I think we'll open up to questions. Everyone can feel free to ask through the chat function, or feel free to unmute yourself and just ask away. While we're waiting for questions, perhaps you can address how you've dealt with a work-life balance issue.
Mm-hmm. Sure. So, you know, and that's, you know, my career trajectory has changed a little bit in the past couple of years because I had children. So medicine for me has been a great field because prior to having children, I was able to do a lot in the hospital. So I did research, and I did clinical, and I was an associate program director, and it was really exciting. I kind of was able to dabble in all these different fields. After having children, I did make a personal decision to step back from all the responsibilities that I had, which was difficult, but I think in the short term, it will be worth it. And so now I'm pretty much doing just clinical and the teaching at night for a short period of time, and hopefully we'll get back into everything I was doing before once my kids get a little bit older. So the nice thing about my job is that I was able to do that. You know, I don't think that that's always possible in other careers.
Great, great. Any questions from the students?
Yeah, I have one question. Thank you, Dr. Katinas, for coming through. I guess I look at, you know, I think back to my medicine rotation, and pretty interested in applying to internal medicine. One thing that I look back on that was sometimes a little bit less satisfying was kind of navigating through a lot of the social red tape that unfortunately exists in our healthcare system. I was wondering if you could comment on, as an attending, how much of that you yourself have to tackle on a day-to-day basis, and how much, in a sense, pure medicine you can enjoy taking care of.
Right. So, and again, there's a big distinction between the outpatient world and the inpatient world for that. So for the outpatient world, and again, I had done outpatient for a while, back when I first finished residency and fellowship, there's a lot more red tape in the outpatient world, you know, in terms of sometimes there are issues trying to get studies done that you feel very strongly that are urgent and that should be done quickly, and you're having issues with insurance companies and whatnot. It requires a lot of patience. It requires a lot of phone calls. I can't think of a situation where I ever didn't get done what I needed to get done, but it was a little bit more work, and again, a little bit more communication that was required than I would have liked to have had to do. On the inpatient side, we don't have quite as much of that because everything is kind of readily available. You know, if I want a CAT scan on somebody in the middle of the night, I can get a CAT scan on somebody in the middle of the night. The hospital, I have, you know, reasons that are easily justified, and it's right there. So I think being a hospitalist, that's part of the reason why I stayed in sort of hospital medicine is It's a quick pace. Everything kind of gets done quick. You can get consults quick. There's not that big wait time in the outpatient. What I lose on the inpatient side is continuity of care of my patients. And I do miss that tremendously. I do miss, kind of starting at a point with a patient and working with them through their medical issues, their social issues, their psychological issues. There's something really gratifying about that. And I think, yes, there's red tape, and there's always going to be red tape. I think the motivation to sort of, navigate your way through it is you are doing this amazing service for a patient. And, when you do get things done and you get your results back and you can finally figure out and put things together, it's just so gratifying. And I think that's something you have to sort of take the good with the bad, and the good is so far much outweighs the bad.
Dr. Katinas, thank you. And off of that note, I think one of the big challenges I found on my medicine rotation was not necessarily the red tape in the hospital, but a lot of the patients that I had either been to the hospital many times in the recent months, or actually we had one patient who was on our team for 6 months straight by the time I got there. I guess how do you find ways to make that experience still rewarding? And have you seen your colleagues or yourself experience any sort of burnout from patients you feel like you can help for non-medical reasons?
Right. And, there's the sort of revolving door concept of patients who they get admitted and you do all this work to kind of stabilize their medical issues, and then they get discharged and they don't have access to their medications for any number of reasons, or there's, things that happen that they wind up back in the hospital with the same problem that you felt like you just fixed. And then again, you do have sort of patients who you can't fix a lot of their problems and they are in the hospital for a month. And that group of patients, there could be many reasons for that. So I have to say, kind of stepping back, one of the great things about having trained in palliative care, most of those patients who are there for the long term, I feel like what they need and what part of the issue is palliative care and kind of figuring out what the goals are. So I feel like that training that I had at Sinai and fellowship really has helped me to communicate with patients, consultants, families really well, to kind of help navigate, why is this happening? What's going on here? I think for the most part, and I say this to the residents also, there's always so much more going on with a patient than we know. There's a whole history. I mean, when a patient walks through a door, they have years of history behind them of exposure to medical care, life circumstances that we don't tend to understand. And I think most of the issue with that is it requires a lot of communication. I don't know if that answered the question.
Dr. Katinas, thank you for giving us all this insight. I'm Louis, I'm on MS4. I just had a question regarding residency interviews and how to prepare for them. I applied to FlexMed. So last time I was in an interview was about 7 years ago. So I was just wondering any tips that you may have for just preparing and how to sell yourself to residency programs.
Right. I mean, I think, so when I was a chief resident, I actually did interviews for medical students, also for residency. And I think the biggest thing that people want to understand when they're interviewing you is what drives you, what motivates you, what made you choose internal medicine. And I think even people are still at this stage of the game wondering what made you want to be a doctor. So I think if you go in there prepared with all of those kinds of ideas, what made you go into medicine? What was your driving factor? Why did you choose internal medicine? Within internal medicine, you can make so many choices about your field. You can specialize, you can generalize, you could be inpatient, you could be outpatient. What are your thoughts about all those processes? And I think that those were sort of the major questions that I felt like I started with. Most of the time when I was doing interviews, I felt like once you ask those questions, the answers kind of lead the rest of the interview. And so I think if you have, really well thought out answers about why you're doing what you're doing, I think that will get you through most of your interview.
Thank you.
Any other student questions?
Another question. You said you came across a lot of specialties that you found interesting. I feel like I'm kind of in a similar boat. How did you go about, I guess, what influenced your decision to go into palliative care and geriatrics?
Sure. So again, I went through residency liking everything, and that was part of my issue. And I was actually really relieved when I was asked to be a chief resident, because that gave me another buffer year to kind of figure out what it was that I wanted to do, because I still didn't know at that point. So when I was a chief, it just so happened that I was put on a committee with some of the geriatricians in the hospital. And I was, again, still really broad, still somewhat undecided about what I was going to do. I was actually even thinking about doing just a general medicine research fellowship, just because I felt like I wasn't quite ready to be an attending. I felt like I needed more experience. And then when I was put on this committee with the geriatricians, they really had a great argument for why I should do geriatrics palliative care. And their thought was, if I really am so broad and so general, and I kind of like everything, which is where I was at the time, I probably would do internal medicine or general medicine. So much of the internal medicine population that we treat now is geriatric. And it would be really wise of me to have a really more advanced idea of how to treat geriatrics. And with geriatrics comes palliative care. Now that people live a long time, there's a lot more chronic diseases. There's a lot more choices for chronic diseases than we ever had. So that's kind of how I wound up in the geriatrics palliative care route. Again, when I first came out and got my first job, I was doing all three. I was doing geri consult, pal consult, and some hospitalist months. And I actually really loved that. But over time, I really liked the hospitalist path more. And so I kind of just got funneled into that and have never regretted that decision.
Could you give us a sense of how you would recommend that students prepare for their sub-Is in medicine?
Sure. So preparing for the sub-I, and even now, so when I have, every once in a while, we get a fourth year student at night, and it's really wonderful, and I love those moments. So, and what I always tell them is, once you get your patients, you become the expert of your patients. So, you get your patient, and the great thing about being a fourth year is usually you have more time than the intern or the resident or the attending. You can ask all the questions in the world, just gather all your data, sit there, put it together, and learning your format of how you write your note and how you present is the same thing. The HPI, the past medical, the past surgical, really hone that down and know it well, present it well, and then have all the knowledge of what your patient has on the back burner. So if you admit a patient with lupus, you want to know the diagnostic workup. You want to know what treatments they've had, what the lab work is, all of those things. And again, you be the expert of your patients. And I think that's a great way to become part of a team, because a lot of times you're going to bring things to the discussion that nobody else uncovered about the patient history. And maybe people don't even remember about the disease itself. So that would be my best recommendation, is take every patient as like you own that patient and you own that medical disease.
Any other student questions? Okay. Dr. Katinas, anything else you'd like to share about your day-to-day experience?
So day-to-day experience, again, for medicine, this is the other thing that didn't really come up, is that, the idea of specializing, and that is a big choice. And so the people who I work with who've specialized, they've chosen their specialties for any number of reasons. But I think once you do decide you want to specialize, it's something that, if it's a very competitive field like GI, like cardiology, that kind of thing, it's something you kind of do need to know a little bit earlier than later, purely for research reasons and mentorship reasons. So, if you happen to be somebody, and again, I wasn't that person, but if you happen to be somebody who knows early on that I really want to be a cardiologist, definitely start kind of getting yourself into that field early on.
Any other student questions?
Yeah, I could ask one. So let's say, like, from what I hear, especially like some of the more competitive fellowships, you kind of have to like get involved in some research while you're in your residency. So how do you go about like finding mentors and finding time to do research while you're working crazy hours?
Yeah. No, it's true, and it's a balance. And I think, the research project that I did a few, and most of them were sort of more chart review kinds of things that you can do on your own time. So when you're doing something like outpatient, which tends to not be as busy as inpatient, you can go review charts. In terms of finding mentors, I actually found that people were more than willing to take on, even medical students, residents. I did some research as a medical student too. And once you express interest, most of the time people are thrilled to bring you on to do part of the research. And again, what you can do also is the research doesn't have to be a novel project. You could jump onto a project that's already going on and have like your part of the project that you do that contributes to a bigger project, and then you're still involved in that research project. So I think you can be flexible and you could be broad about it. But I would say that the first thing is, so I don't know if Dr. Hoopercar is still there for ID, but when I was really interested in ID, I just sent him an email and said, what kind of research are you doing? Is there something I can do? And he had like 5 projects for me right then and there, and I could pick one.
Thanks.
Sure.
Do you maybe talk a little bit about, I know you mentioned inpatient versus outpatient. I don't think we have much exposure to different types of hospitals, community hospitals, public hospitals, private hospitals, and then also different types of outpatient practices, whether it's a group practice or a part of Mount Sinai, for example, or independent practice. What do those different options look like?
Sure. So doing a residency at Mount Sinai was wonderful because there were 3 different hospitals that we utilized. So Elmhurst is your classic community hospital. And I think for sub-Is, you could still go to multiple different hospitals, right? But it's just one hospital for that period? Okay. So, it's not something you're going to be able to do for the sub-I, but for the, when you pick your internal medicine residency, I do think it's important to find a hospital that has a diversity of experience. So I knew going into Sinai that I would go to Elmhurst, that I would go to the VA, and that I would be at the main, sort of the mothership. The VA operates completely different than Elmhurst. Elmhurst operates completely different than both of them. So I felt like that gave me a very good idea of what happens at different kind of hospitals, big time academic versus community versus the VA. And in terms of where I practice now, it's more of a community hospital that's getting a little bit more academic as we go on. And, we're trying to sort of push for that as attendings. But I think, again, kind of looking to where you want to do internal medicine residency, I think it is very important that you look for a place that has a diversity of experience. In terms of the outpatient world, really the only experience you're going to get is probably the practice through your hospital, through your academic hospital. When I was, I don't remember if this was residency or if this is when I was a medical student, there was a mentorship where I went into a private practice. So I was able to see how a private practice worked. And it was a sort of a 2 to 4 week thing where I went in a couple of days a week, and maybe it was part of the outpatient rotation. I can't remember, but I did have that ability to see what a true private practice was. And, again, all of those are great. I think everybody kind of finds their niche and decides, what works best for them. But again, I think you really want to pick the right residency that's going to give you diversity.
I guess along those same lines, do you have any guidance on how we can better evaluate other residency programs as we're applying in like the COVID age with only virtual visits? I don't know if second looks are in the equation, but assuming they're not, but how do you recommend going about that?
Yeah. And again, COVID makes everything different, right? Because back when I was applying, we were able to do electives in hospitals that we were interested in. So for example, I did an elective at Columbia because I thought that might be a place I wanted to go. I don't know that that's something that's available anymore. If it's not, I think probably the best thing to do would be to see if house staff have, and I don't know, Dr. Dweck, you would probably know better than I would. Can you get in touch with house staff from other programs? Like, for example, if somebody was interested in going to Mass General, if somebody was interested, do they have some kind of a program where you can talk to the residents who work there?
So it can be done indirectly.
Mm-hmm.
People can contact the program coordinators at a particular institution and ask for a connection to a resident.
Mm-hmm. Okay.
So the coordinator is the administrator.
Mm-hmm. when I was applying, I remember specifically when and only because I knew Sinai had such a diversity of hospitals. So one of the main things that I looked for before I applied to another institution was, do they have a diversity of hospitals? And so if their residents were only at one hospital, I actually didn't apply there because I knew that that was probably not going to be to my benefit in terms of experience in the long run. So I made sure that there were minimum 2 to 3 hospitals that the residents rotated through.
Any other questions? Okay. Perhaps you can describe for us how a student during the interview can present a case in a short way that when they're asked, tell us about an interesting patient you've seen, how should they frame that answer?
Oh, that's a great question. So I actually even remember the patient who I talked about in my interviews. And she was a lovely woman who I think I enjoyed talking to her in general, but she had a really amazing medical story. And so I remember the way I started was talking about her as the person that, one of the first things I recognized when I walked in her room was she had these bright eyes and she had lots of questions about me and she was so polite and so kind. And then on review of everything going on with her, all of these just amazing things were happening to her body. And it was unfortunate, but she did well in the end. She had lung cancer and she had waited so long to diagnosis that she had just about everything you could imagine in terms of complication. And so I started off talking about her as the person. Then I talked about how, the first thing I did was look at her labs and I said, wait a second, what's going on here and what's going on here? And then I pulled up her chest x-ray and that was a moment of amazement at what was going on and complete sorrow because I had.
Okay. Dr. Katinas? Yes.
Yes, she's back.
We cannot hear you. We can't hear you. We can't hear you.
I don't think she can hear us.
You're muted.
Oh, there we go.
Okay.
We still can't hear you.
Still can't hear you.
She's unmuted on our end, so she should be able to.
Okay. So I think she said she's going to sign off and come back.
Okay.
Dr. Duck, where's that background from?
That was my Brooklyn office.
Oh, okay.
Right? You were there.
I see the coffee maker in the back.
Right. Yes, exactly.
Can you hear me?
We can
Yes.
hear you now, Dr. Katinas.
Okay, great. I apologize. I'm on my son's iPad and I cut him off at 7, but I forgot about that. So back to my patient. So the jump that I made in the interview was that I had met her and I just liked her so much as a person. And then after reviewing her labs and her films and seeing what actually was going on with her, I was amazed as a doctor and devastated as a person. And so I sort of talked about how, I followed her daily and, it was, again, that sort of this conflict that I had between just liking this person so much and at the same time being fascinated by her medical disease. And so that kind of led to a lot of discussion about just how you, as a physician, how you kind of walk that fine line of being involved with a patient and showing compassion and empathy, but also kind of how you put up a little bit of a barrier so that you don't get too emotional about things as well. So I remember that being like sort of a big jumping off point.
Can you give us some examples of questions that students can ask at the end of the interview?
So for residency, I think, and we kind of talked about this already, and one of my big things was what kind of a diversity of patients are we going to see? And I even wanted to make sure, back in, especially through Elmhurst, I wound up learning a lot of Spanish. So it really was important to me that I see different demographics, different languages. And so I wanted to know about the diversity of patients, about the diversity of the clinical care. And I also did want to, because again, I wanted to kind of do everything. Every program has a different outpatient setting. And so I really wanted to know that there was a strong outpatient component, because I knew that there would be obviously a strong inpatient. Sometimes that's not always the case about outpatient. And I think the other thing I asked, I'm sorry to interrupt, I also did want to know specifically about how research time worked into the schedule, because at the time I was interested in research, and how electives worked as well. So those were two things that I found important.
Any other questions, students? Dr. Katinas, anything else you think that they should be aware of in terms of the application process, the interview session, looking at the program, researching the program? What are the other important things that they should look for?
The other thing that's it is a match. And so you want to make sure that where you apply, you will want to live there. You are comfortable in that city. It's nice to have a support group. And I think that you work very hard as a resident, and it's a lot of hours. And, if you're leaving and going to a different town, what kind of a platform do you have for taking care of yourself and supporting yourself as well? And I think that is a big component that we all kind of forget. We're very, very goal oriented and very career oriented, but you want to also enjoy life. And so, I have to say, staying in Manhattan was a huge pull for me. One, I have family in the area, but the other is that there was a lot of culture. So on those, few hours a week that you have off, I was able to go and see plays, or I was able to go to Central Park. I think you also want to make sure you take care of yourself as a whole.
Great advice. Great advice.
And I do think the other thing, back to the interview and sort of thinking about that question that you posed about a patient encounter, is I think people also want to see that you're still human, and that you still have human qualities and have compassion and have empathy. All these interviewers are going to have your grades, and they're going to have your scores, and they're going to have your transcript, but they want to see that you're a person and that you can relate to people. I think, and again, doing palliative care, communication as a doctor is so important on multiple levels. Every day you're communicating with your patients, you're communicating with your families, you're communicating with your colleagues. And so one of the things to remember in that interview is that your interviewer is going to want to see, are you somebody who can speak well, who has a nice presence, who has a calm presence, who can present yourself well, who can explain things well. I think those are all important characteristics to remember going in.
Excellent point. Thank you for sharing that. Very good. Any other questions, students? Okay, well, Dr. Katinas, thank you so very much for spending this time with us.
Oh, you're very welcome.
We'll have you signed up in the database so that students can reach out to you, and perhaps you can mentor a student or two down the line. Okay.
I would love that, absolutely. And if anybody after this session has any questions that come up that you realize you didn't ask during the session, by all means, feel free. People can email me, people can reach out. I'm happy to help.
Great, great. Thank you.
Katinas, if I could just take a quick screenshot. Thank you.
Sure.
Thank you, everyone, for attending. Enjoy and good luck.
And
Thank you, Dr.
good luck to
Katinas.
everybody, especially with the new challenges.
Have a great evening.
Okay, take care. Bye-bye.
Good night.